Hi, everyone. Welcome back to Functional Medicine 2.0 and today's episode. I'm so excited. But first, let me introduce Lorri, family nurse practitioners, one of my friends, and our clinical director. Hi, Lorri.
Hi, Dr. Z. Thank you so much for having me here today.
Thanks for being here. So our topic today, I'm excited to talk about it because, clearly we love labs. We work with labs all the time.
Yeah.
But our topic is the $20,000 lab myth. Why more testing is making you a worse clinician.
And we love tests, so this is going to be fun.
Yes, we do love tests, but it's very important. So again, this is something where, traditional medicine, we're complaining they're testing just for disease. People don't automatically jump into disease. They walk, they crawl, they run there. We can certainly see things earlier. A lot of lifestyle issues don't show up when you're looking at a traditional blood lab just for disease. But then sometimes I think in functional medicine 1.0, it's swung to the opposite extreme where now I'm just going to order every lab there is. And they're confusing data with care. I don't know. What do you see, Lorri?
Absolutely see that. I know when I first started in practice, that's where I came from as well, right? With looking for more data points to try and come up with an actual plan or a diagnosis rather than doing the work of listening to the patient, looking for patterns and diving in through their history. So yeah, it's an evolution.
Yes, same, same for sure. And I think some in FM 1.0 they're going the wrong direction. You need 3,000 in labs up front just to get started. You need 5. You need 10,000. I've seen crazy numbers, and I can't work with you unless you do all that. And I think we're missing the mark there. I think especially since patients are paying for this, right? They're paying out of pocket for these labs. We have to be very decisive. Of course, we don't want to not order a lab that is needed where we miss something. So we don't want that to ever happen, but to really be more specific about what lab is going to reveal information that's going to actually change my protocol and the clinical outcome. And I think that takes a bit more work.
Exactly. I found over time, when I initially started, say I might order 2 advanced lab tests in addition to serum labs, and I would get so much information back that my head was spinning, right? I didn't know where to actually start. So reworking that into that functional medicine 2.0 sort of framework where we are listening to the patient, we're listening to the patient. And that is truly helping drive what labs we're going to order very pointedly, right? We're looking for an answer specific when we order these labs. We already have an idea of what's going on before we order 5 panels of labs.
Yes, absolutely. And I think the labs also have to do more than just, validate what you suspect, even though sometimes there's those patients that just need to see stuff in black and white before they're going to take the action. So I get that. But I think the labs really have to drive a clinical decision. So part of how I would handle it is I would talk through this with my patients and, talk out loud. So I think that's so important. But I don't know, tell me your thought on this. I did care for years and I've taught it many times where that patient came in and we wanted to learn everything there was to know about them in one visit. So that was overwhelming, a lot of pressure on everyone involved. And then we had to figure out the exact right labs to order them all at once. And then we'd go to a report of findings where we tell them everything there was to know about them. And then the gap between these 2 visits would be 3 to 7 weeks sometimes. Because maybe you were timing a Dutch test with, someone's menses, and maybe there was a delay in this from the lab or, all these kinds of things. And I did it for years. I did it with thousands of patients, but I needed to see them more frequently. That was too much of a gap to come in, sign up for something, have to wait so long. And what really changed my mind on this approach is when I could start working with them, what we call biohacking human behavior, but actually being the clinician that would guide them through change from visit to visit. Lab I thought I needed, all of a sudden I didn't need anymore, or something else came up. And so for me, a big change, I know you've seen it, you teach it too. I look at that 3 to 6 month initial time that that patient comes in, that you work with them, that whole thing is an intake and that whole thing is a report of findings. It not only takes the pressure off and costs less, but it makes it much more manageable for the patient who didn't want to go get their PhD in biochemistry. And so they could do it, visit by visit. I don't know. I just said a lot, but what are your thoughts on that?
I fully agree, right? If when I had the same sort of experience when I initially started, I'd order something, maybe see someone back 6 months later, and in the meantime, the patients at home, they're overwhelmed. You've told them, make all these foundational changes because when you come back in 6 weeks, we're going to start tackling what we see on the labs. And that's too much. You're forcing it. It's too challenging for the patient to do. It's too challenging for the body to do. And it's overwhelming for the practitioner who's trying to keep with this timeline of let's get them through the system, right? Rather than looking at the person in front of them, developing that precision sort of care plan for them one step at a time.
Yeah, 100%. I totally agree. And sometimes it's gonna sound mean, but sometimes I feel like it was functional medicine 1.0 theater. Like how to do a case review. I remember, going through IFM and doing a case review, and I signed up for extra services. I was meeting at 6 a.m. with physicians and doing
Hmm.
all this testing, and it was a great learning experience. But there was no way that that was practical to do with patients in real life. And I did feel like ultimately it was theater, and we're not doing this work to just write a great case review. We're doing this work for a human being in front of us to get change. And so it absolutely changed the way I did care. And like I said, shockingly at the time, now I get it, but shockingly at the time, saved them money
Hmm.
because we could make changes, visits 1, 2, 3, 4, 5. And that test I thought I needed, I didn't need anymore, but maybe something different cropped up. And we got that test visit 7 instead. So I definitely moved towards I still love labs, but being super selective about getting the right labs and when, and seeing the patients more often doesn't have to be as long. More that makes it more manageable on the staff, but also the patient's able to take it in and hear it.
Right. Yeah, and more labs doesn't equal better care. It often will mean that things get delayed, right? You end up laying out UC if you do a GI map and a Dutch and serum labs. You see 18 months of work ahead, right?
Mhm.
Who's going to be overwhelmed? Everybody at that point. Where do you start when you have all that information? It can be very confusing. So going in intentionally with an idea in mind of this is what we're looking for. I want proof that this is what we're dealing with, right? And then when you get that lab back, making that best next step for the patient.
100%. I'm going to throw a little quirk in here too. Something I learned working with people. I always say, it's not just a practitioner patient relationship, but also a business owner consumer. So we have more responsibility, than when you come from traditional medicine and you have patients just presented to you and, you clock in and you do your work. It's a completely different environment when you own your own business. And if you don't meet that patient where they are and serve their like number one complaint, you're going to lose them. They're not going to
Mm-hmm.
be happy. Maybe you're even doing a good job, like getting to the root cause and getting under it, but they don't understand it. You haven't communicated it to them clearly, and they haven't seen a win yet, like the importance of those early wins. So then they're out of here. And they're going to
Right.
take their business, somewhere else. So I actually, besides, even now, not just besides, but before I would even think about the labs, what was the patient coming in with? Did they bring some diagnoses to the table already? What were their top 5 complaints? And then what I learned to ask, I'll tell you one of the patients who really taught this to me, but it was a patient, very complex history, some serious medical conditions. And I said, okay, what are your top 5 complaints? She had 10. So she had 10 symptoms and they, started like really serious, cardiometabolic issues and blah, 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 blah. And the last one on our list was dry eyes. And so it'd be very easy to just sort of ignore that, right? You know, it's small, it's last on the list. And so this is a question I started using. I said, well, if you could wave a magic wand and have one symptom be gone, what would it be? And she said dry eyes. And I was like, oh my gosh, ding, ding, ding. Like, this is what it means to serve the person in front of you, because that is what's most important to her right now. I don't know. Did you have any experiences like that?
Excuse me, absolutely, right? Especially when you're doing the intakes with as a patient in historically, right? When you're writing down your history on an intake or filling out the forms, you have to go through and remember, what are my symptoms? That could be hard when you're living it, and maybe the most annoying one is going to be the last one, because you're going to be like, yeah, it's this freaking shoulder that's driving me nuts, and can you help me? Yeah, that's a very, very real. And asking that question of your patients, in addition to helping them get the sort of support and feel heard and move the needle on their health sooner, you, again, going back to you being the business owner, you're addressing their need, right? And that's why you're here. If you're in functional medicine, you likely have a servant's heart. You want to be out here helping people in your community. And if you aren't taking what their needs are into account, you're missing the boat.
Yeah, 100%. So that was definitely a big, eye opener for me. And focusing on that, realizing that they weren't just patients, but they were consumers coming to the table and serving them, and getting those wins and letting them know I'm paying attention to it. Like, if I can get those early wins, that's the ideal scenario. But if for some reason it has to be delayed, we're talking about it so they know why that's being delayed. And that earns trust and starts buying you the time to do the real work. Because, I mean, it does all take time, right? Like you said, if you get all those markers, you see 18 months worth of work. And that's not great for marketing and sales. When
Right.
people want to come in and they just want a quick fix and they want to do, they only have one thing on their mind. And then you see 18 months worth of work, you're going to have to meet them where they are first, and win that trust and have them start feeling better. So then their vision opens up to, where can I take this? And, oh, I came in just for weight loss, but now I can deal with, hot flashes. Now I can deal with hair loss. Now I can deal with my sleep's a mess. Maybe I could actually start feeling better, not just the one thing that brought them in.
Right, and chunking it out into smaller, attainable goals, right, is going to give them the dopamine, give them the feedback, help them buy into this is working, rather than looking at this longer timeline. And that's exhausting. It can be. And it's the rare person who says, okay, sure, let me put in 18 months of work, let's go. Right. But if you say, hey, work with me over the next 4 to 6 months, and we're going to see these changes, that is something that the patient can then own and embody and feel proud of and actually accomplish.
Yeah, absolutely. And I do love labs for like stringing those things together, for the patient seeing that. And I used to say to my patients, like, okay, we're doing a retest in a couple of weeks. So this is like, we're training for the marathon. We want to have good numbers, anything I could do to incentivize them or gamify them or bribe them to do well. So depending on their personality and what works for them, if it's making it sport, if they're competitive, if they, whatever it was that I could use to motivate them, and all for the sake of biohacking human behavior, right? Like, if they can get a win or they can make a behavior change, then they see it's possible. If we start stacking them up and they start making them consecutively, then they see this could continue. And then maybe later that can become a new identity for them. I'm no longer the identity of the stressed out mom who never gets sleep. I'm now a mom who rests well, so when they start changing their identity, that becomes so much more powerful, because, we also want to get lasting changes and changes that can stack on one another. But what do you think about this idea? I mean, I feel like we've both worked with enough practitioners. We've probably both seen it, but that clinician anxiety, about
Yeah.
can I help someone and can I help them actually get the change, they disguise it as science and lean on the labs as like a shield and to sort of, mask what's really required. And we talk about in FM2 what's really required to help the person. I don't know. What do you think?
Yeah, analysis paralysis is still a clinical decision, just not a good one.
Oh, I like that.
Right,
I
right.
like
I
that.
mean, we don't want our visits to turn into lab lectures where we're like, let me tell you all the things that I know about these labs that tells you about you. That might be something that you as a practitioner gets really excited about and because you're a nerd and you want to get into all the nitty
Yes,
gritty and actually understand
absolutely.
it, right? But the patient, they're going to be overwhelmed and they just want they don't just want, but they need the coaching, they need the care plan, they need their handheld. Here's what we're going to do. If you're just spewing about, oh, look at your beta glucuronidase and we need to get this and move this, and it's just not. It's masking you. It's putting a barrier between you and the patient and actually moving the needle on their wellness.
Oh, I love that. I so agree. And that's one of my complaints about FM 1.0 is I feel like there were just a lot of people, practitioners, well-meaning, but on stage saying, bow down, I'm the guru, and let me talk
Mhm.
about this, hormone cascade and this enzyme. Did you know that this enzyme does this? And then you have all these practitioners in the training going, oh no, I didn't know that. And then on Monday, like crickets, how does that translate to patient care? And how does that translate to communicating with a patient? So yeah, I also say like, if you're marketing or talking about methylation in visit one, you've already lost. Like, what's happening here?
Yeah, patients don't need more explanations, they need movement.
Yes. Yes. Can we just like breathe that in for a moment? Action over data, like
Yes.
results over like patient outcome results over just lab change. I mean, I love lab change, but we need patient outcome. Um, and I was just saying this the other night that we can't solve obesity with yesterday's science because if it worked, we wouldn't have 60% of the US population overweight,
Hmm.
right?
Hmm.
So we've learned so much about obesity and it's so good. There's still more to learn, but you've done the certification and taught it to all the practitioners what it really means to address it and all the complex issues involved. Now that we know that, how do we translate that into patient outcome? And that's where I think biohacking human behavior becomes so important. I mean, what do you think? Do you think practitioners are going to start understanding this more? And are they going to be willing to do the coaching or get coaches?
That certainly that's a goal that we have with our clinical team here at FMA. We picked a word for the year, and our word is patterns. Last
Mm.
year it was foundations. This year it's patterns, and that is to help practitioners to start recognizing patterns in the whole body and the whole system. Because really, if you're doing all that testing as the practitioner, it's going to help. It may help soothe your clinician anxiety, right? But it's not necessarily going to improve your outcomes. So you need to be able to identify similar patterns that you're seeing that will help drive your direction in diving deeper.
And I'm going to just say too, because I know, I think we talk about this next week, but, and not just the patterns, the clinical patterns, the lab and data patterns, but the patterns in human behaviors and different people's personalities. Like, I mean, that's the good part and the worst part of working with people, right? Is we
Yes.
can't just give them a handout and call it a day, no matter how good that handout is. Everyone's unique. So they might be unique in how they actually metabolize. It might show up very physiologically different, but their personality, their behavior, their trauma, their motivation, what gets them out of bed, what gets them moving, who's really going to change their meal plan. And is it enough to change a meal plan for short term, 6 weeks elimination diet, or what's it going to take to do a behavior and change that identity so they start changing their lifestyle? Otherwise, they're just going to rebound. Yes.
Exactly. And going back to your point, right? If the lab that you're ordering doesn't change your plan on Monday, then it shouldn't be ordered on Friday.
I totally agree. I think that's going to be new thinking for a lot of people
Yeah.
because, we both get a lot of practitioners straight out of the hospital. And they're used to protocol care. And, sometimes I pick on protocol care. Sometimes it makes sense for what you're trying to accomplish. So I see both sides of it. But when you're dealing with this smaller volume of people, you own your own business, this is personalized care, it's not going to work like that. So you have to be taught, how to critically think and be decisive, because we're not going to be able to say patient A, B, and C, here's the protocol for them, and it's going to work that way every time. But I think some people are coming out of that system.
Yeah, and the system is what it is to do what it needs to do, right? It's there to help manage acute life-threatening situations. So it's protocol driven. You don't have to make decisions at the moment because it is so urgent. It's very different from wellness care, which is what functional medicine is, right? It's for people who are looking to truly optimize their health, certainly potentially reverse disease and such. But I see this again and again in our classes, and our practitioners are coming in wanting to know what is the protocol, what is the next, or what is the easy button thing for this condition for everybody, rather than the precision sort of medicine thinking of each person's an individual. And it just requires, it's not saying that it's wrong, in that you need that protocol driven, you need to know what to do if someone comes in with an MI, and the team works and you just take care of it. But if you have someone coming in with SIBO, that's a whole different approach. And as the clinician, you have to make a complete 180 in your clinical judgment and thinking skills, from that protocol driven to that individualized, starting to question the patient, dive into what's going on with them. And that can be very unsettling. For the practitioner, if they're coming from, I see you, and then you're out the door 2 doors later, and I never see you again, or 2 days later, right? So this is continuity of care that has to be learned and understood, how to carry a patient through a transition. So yeah, it is quite different.
Well, our emergency department physicians and nurse practitioners, they're like, we've never done continuity of care, so that's completely different. But even some of our surgeons, are like, well, what the heck am I doing now? I'm used to just going in and cutting, right? Like, this is completely different. So I actually love and admire the physicians and nurse practitioners that are making that switch. It's so cool to see, and how they expand as a practitioner and expand their thinking and really look at that person in front of them. They're not just a puzzle piece, but this is a human being. So I love that. And I think that's wonderful. I think also, just to sort of get towards the end where we're wrapping up here, but FM 1.0, I think, started to go down that path, but then they got all caught up in the rabbit hole. And they were creating too much work for people, where it was 10 hours for a new patient to come in. So like, oh, okay, I get that I'm supposed to do the individual care now, but then this practitioner who's starting out wearing all these hats, I know there's so much we could say on this, so I'll keep it short, but you can't sustain 10 hours of research and rabbit holes going down that rabbit hole for each patient. It just won't work for building a practice. So I know we've built some amazing tools to help with all that, but I think the real point we're trying to make here is the practitioner still is the clinician. They're the guide. Nothing replaces them being able to, as you said, see those patterns, be able to be decisive, make a decision. Anywhere else they can press the easy button and make life better, I'm all for it. But nothing replaces serving that person in front of you and making sure we're not hiding behind 20K worth of lab data.
Exactly.
All right. I want to thank everyone for being here. It was great, listeners. We'll see you next week for another episode, Functional Medicine 2.0. Thanks, Lorri.
Thank you.